All right, welcome back everyone. We're shifting anatomical gears now and moving into the cervix, the not so glamorous but extremely important gatekeeper between the uterus and the vagina. From a histotechnology standpoint, the cervix is fascinating because it's one of those areas where anatomy, histology, screening, and cancer prevention all collide. The cervix isn't just a passive tube. It's hormonally responsive, structurally unique, and, most importantly for us, home to one of the most clinically significant epithelial junctions in the entire body. If there's one structure to mentally highlight today, it's the squamo-columnar junction. That little transition zone does a lot of heavy lifting in pathology. Think of the cervix as the biological version of a border crossing. Two different epithelial populations, constant cellular turnover, and unfortunately, where problems like to start. All right, let's talk cervical carcinoma. And this is one of those topics where pathology genuinely changed history. Back in the 1950s, invasive cervical cancer was actually the leading cause of cancer-related death among women in the United States. That's hard to imagine now, but at the time, most cases weren't caught until they were already invasive. Fast forward to today, and cervical cancer deaths in the United States have dropped by roughly 70%. That kind of reduction doesn't happen by accident, and it didn't come from better chemotherapy or fancier surgery. It came from screening, specifically the Pap smear. The Pap test works because cervical carcinoma doesn't appear overnight. It develops slowly, moving through recognizable precursor stages, dysplasia and cervical intraepithelial neoplasia, before invasion ever occurs. From a histology standpoint, this is incredibly important because it means cellular changes happen long before architectural destruction. That's why routine screening focuses on sampling the squamo-columnar junction, the area where stratified squamous epithelium meets columnar epithelium. This junction is biologically unstable. Cells are constantly dividing, migrating, and remodeling, which unfortunately makes it the perfect environment for mutations to take hold. If you remember nothing else about cervical pathology, remember this. Most cervical carcinomas arise in the transformation zone. And from the lab side, this makes specimen quality critical. Poor sampling, crushed epithelium, or absence of the transformation zone can significantly limit diagnostic interpretation. So even though a Pap smear looks simple on the outside, what's happening at the cellular level and later in histologic follow-up biopsies is anything but simple. A fun fact, the Pap smear is considered one of the most successful cancer prevention tools ever developed, and it's largely responsible for shifting cervical cancer from a common killer to a largely preventable disease, which is a pretty powerful reminder that what happens on your microtome bench can really change outcomes. All right, now let's switch gears and look at what cervical carcinoma can actually look like grossly, because this is one of those cases where the specimen tells a very loud story before we ever get to the microscope. What you're seeing here are hysterectomy specimens with invasive cervical carcinoma. Grossly, cervical cancers often appear as firm, irregular masses, areas of ulceration, and regions of necrosis, and frequently poorly defined borders. Unlike something like a leiomyoma, which politely stays round, smooth, and well circumscribed, cervical carcinoma does none of that. These tumors tend to be infiltrative, meaning they don't respect tissue planes. Instead of pushing tissue aside, they grow through it. You'll often see a barrel-shaped cervix, thickening of the cervical wall, distortion or obliteration of the cervical canal, and extension into surrounding tissues. From a histotechnology standpoint, this has real implications. Invasive cervical cancer is notorious for variable tissue density, areas of friability mixed with dense fibrosis, extensive hemorrhage, and patchy necrosis. So translation, these blocks are not always friendly. You may notice that some areas section beautifully, while others chatter, fragment, or behave like they were personally offended by your microtome. That's not you, that's the tumor microenvironment. Another important gross point, invasion depth matters. How far the tumor extends into cervical stroma, parametrial tissue, and the vaginal cuff directly affects staging and patient management. So when these specimens come into the lab, orientation, inking, and proper sampling are critical. A few millimeters can make a major difference clinically. Cervical carcinoma often spreads laterally before it spreads upward or downward, which is why parametrial involvement is such an important staging feature. So when you're embedding or cutting these cases, remember, you're not just making slides, you're helping determine how far the disease has traveled. All right, let's pause here and actually look at what we're dealing with anatomically. This is a gross specimen of the cervix, and I want you to notice right away that the cervix is not some tiny afterthought hanging off the uterus. It's a thick, muscular, collagen-rich structure that takes a lot of abuse over a lifetime. From a histology standpoint, this matters because the cervix has two very different epithelial personalities living in one small space. On the outside, the ectocervix, we're dealing with stratified squamous epithelium, very similar to vaginal epithelium. As you move inward toward the endocervical canal, that lining abruptly switches to simple columnar epithelium with mucus-secreting glands. And whenever two very different epithelia live next door to each other, pathology gets interesting. This is why cervical specimens are so important in surgical pathology and why orientation, margin identification, and proper grossing technique matter so much. If the transformation zone isn't sampled correctly, you can completely miss clinically significant disease. So yes, the cervix may look small, but it causes a very big percentage of pathology workload. This slide introduces one of the most important phrases in gynecologic pathology. The squamo-columnar junction, also known as the transformation zone. If cervical cancer had a favorite hangout spot, this would be it. The transformation zone is exactly what it sounds like. The area where columnar epithelium is being replaced by squamous epithelium through a process called squamous metaplasia. Now here's the key point for histotechnologists. Metaplasia itself is not cancer. It's a normal adaptive response. But, and this is the big but, metaplastic epithelium is more vulnerable to HPV infection. HPV loves immature, actively dividing cells, and the transformation zone is full of them. It's busy, it's unstable, and it's constantly remodeling. That's why Pap smears don't just randomly sample the cervix. They intentionally target this exact zone. From the lab side, when we receive cervical biopsies or cone specimens, one of our first questions is, did we actually capture the transformation zone? Because if we didn't, the pathologist's diagnostic confidence drops dramatically. This little strip of tissue is responsible for decades of job security in gynecologic pathology. Here we're zooming in closer on the transformation zone itself. That arrow is pointing to the precise area where the epithelial switch occurs. Columnar on one side, squamous on the other. And histologically, this area can look messy. You may see immature squamous cells, active mitoses, inflammation, glandular openings, and reserve cell hyperplasia, all packed into one small region. This is why cervical biopsies can be deceptively tricky. Something that looks alarming at low power may actually be normal metaplasia, while subtle dysplasia can hide in plain sight. From our side of the microscope, this means excellent fixation matters, thin, consistent sectioning matters, and orientation matters. And losing this area during embedding is not ideal. This is also why cervical tissue tends to show up in teaching sets so often. It forces you to slow down and evaluate architecture, mature patterns, and nuclear detail very carefully. In short, the transformation zone is small, dramatic, biologically active, and slightly chaotic, which honestly makes it the perfect storm for disease development. Now, let's talk about why cervical carcinoma happens, the etiology, and the pathogenesis. The overwhelming majority of cervical cancers are associated with high-risk human papillomavirus, especially HPV type 16 and 18. These are the troublemakers of the HPV family, the ones that don't respect personal boundaries or cell cycle checkpoints. Once HPV infects the cervical epithelium, especially at the squamo-columnar junction, it integrates viral DNA into host cells. This leads to DNA damage and disruption of tumor suppression genes and stimulation of abnormal cellular proliferation. From a histology perspective, HPV proteins, particularly E6 and E7, interfere with P53 and RB, which normally act as the cell's quality control managers. When those managers are fired, cells start dividing when they absolutely should not. Peak HPV infection occurs most commonly in individuals in their 20s, but here's an important clinical and histologic point. Most HPV infections are actually cleared by the immune system, so infection does not equal cancer. Low-grade lesions often regress on their own. High-grade lesions may persist and can progress to invasive carcinoma if untreated. And the most important takeaway for you as histotechnologists, HPV-related changes occur at the squamocolumnar junction, also known as the transformation zone, which is exactly why Pap smears target that region. That tiny zone does a whole lot of damage when things go wrong. This slide shows what cervical carcinoma can look like clinically as seen through a speculum exam. And I always like to remind students this is what the clinician sees. What we see comes later on glass. So clinically, cervical cancer may appear as an exophytic friable mass, an ulcerated lesion, or an irregular bleeding area of tissue. These lesions often arise directly from the transformation zone where squamous and glandular epithelium meet, again reinforcing why that region is such a big deal. From a pathology standpoint, once invasion occurs, malignant cells extend through the basement membrane and into cervical stroma, and then potentially into parametrial tissue and beyond. Grossly, advanced lesions may appear irregular, soft, necrotic, and bleed easily when manipulated, which explains why abnormal vaginal bleeding is often an early clinical symptom. So while the clinician sees something suspicious visually, confirmation always comes back to us with histology. No pressure, just the entire diagnosis riding on your slide quality. Before we move on, it's important to recognize that not every abnormal Pap smear equals cancer. There are several non-neoplastic cervical conditions that can produce cellular changes, and you will absolutely see these in cytology and surgical pathology. Two very common ones are shown here. The Trichomonas vaginalis. So Trichomonas is a flagellated protozoan parasite. On cytology, it often appears as small, round to pear-shaped organisms with pale cytoplasm, sometimes visible flagella, often accompanied by a heavy inflammatory background. Fun fact, Trichomonas doesn't survive well outside the body, which is why wet mounts historically had to be examined immediately. From a Pap smear perspective, you'll often see inflammation, degenerative epithelial changes, and dirty backgrounds, which can sometimes mimic dysplasia, making accurate interpretation critical. Candida, on the other hand, is a fungal organism. Histologically and cytologically, it's known for budding yeast and pseudohyphae, entangled filamentous structures weaving between squamous cells. If you've ever looked at a Pap smear and thought, why does this look like spaghetti? That's Candida. Important histotech note, Candida can cause reactive epithelial changes, nuclear enlargement, and inflammation, but these are not pre-malignant lesions. Recognizing infectious organisms prevents overcalling dysplasia and unnecessary patient anxiety, which is a pretty big deal. So key takeaway from this slide, not all cervical abnormalities are cancer. Some are infectious, inflammatory, and completely treatable. Your role in specimen preparation and staining directly affects whether those organisms are visible and therefore whether the diagnosis is accurate. No pressure again, just public health resting gently on your microtome skills. All right, now we're shifting gears slightly and zooming out from the cervix to look at the uterus as a whole. You already know this organ does a lot more than just show up on gross exams and hysterectomy requisitions. But from a histotechnology standpoint, understanding the anatomy is critical because where tissue comes from directly determines what we expect to see under the microscope. Different regions of the uterus have different epithelial linings, glandular structures, stromal components, and clinical implications, and mixing those up can absolutely change a diagnosis. So as we go through uterine anatomy, keep your histotech brain switched on. Think, if I embed this, what should I expect to see on the slide? Because anatomy drives histology every single time. Here we're looking at gross anatomy of the uterus, and yes, this is one of those organs that looks deceptively simple until you actually start cutting it. At the most basic level, the uterus is divided into three major regions. The fundus, which is the rounded top portion, the body or corpus is the main muscular portion, and then the cervix, the lower, narrower portion connecting to the vagina. From a grossing perspective, this matters a lot. Why? Because different disease processes favor different locations. Endometrial carcinoma loves the body. Cervical carcinoma, as we just discussed, is all about the transformation zone. And when you're grossing hysterectomy specimens, orientation is everything. Anterior versus posterior, endocervix versus ectocervix, and identifying that endometrial cavity correctly before sectioning. Fun histotech reality check. If the gross description is wrong, the histology can look confusing, even when it's perfectly normal tissue. So gross anatomy isn't just for surgeons, it's for us too. This longitudinal section really helps bring everything together. You can clearly see the endometrial cavity running through the body of the uterus, narrowing as it approaches the cervix. From the histology side, this section explains why uterine tissue can look wildly different depending on where the section came from. The endometrium is gland-rich, hormonally responsive, and changes appearance throughout the menstrual cycle. Beneath that is the myometrium, thick bundles of smooth muscle arranged in interlacing layers that can look almost chaotic on H&E. And then inferiorly, as we transition towards the cervix, the glandular architecture changes. The stroma becomes denser and the epithelium shifts dramatically. This is why pathology reports are very specific about location, endometrium versus lower uterine segment versus cervix, because histologically they are not interchangeable tissues. Some worthless but fun knowledge: the myometrium is one of the strongest smooth muscle layers in the human body, powerful enough to contract with over 100 pounds of force during labor, which is impressive and mildly terrifying. All right, now we're shifting our attention fully into the uterus itself. What you're looking at here are longitudinal sections of the uterus, opened to show the uterine cavity from fundus down through the cervix. Grossly, this is one of those organs that looks deceptively simple until pathology shows up and reminds us otherwise. A few things I want you to orient yourselves to: the triangular uterine cavity at the top, the thick muscular wall surrounding it, and the narrowing as we move inferiorly towards the cervix. From a histotechnology perspective, orientation is everything here. If this is embedded poorly or sectioned off axis, you can easily lose the relationship between the endometrium and myometrium, and that relationship is critical for diagnosis. Pathologists don't want to guess where the tumor is. They want to see where it started and how far it went. Your sectioning makes that possible. So mentally start separating this organ into layers, because that's exactly where we're headed next. Here's where things really start to matter diagnostically. This slide beautifully demonstrates the two major layers of the uterus: the endometrium, the inner lining, and the myometrium, the thick, smooth muscle wall. The endometrium is hormonally responsive. It changes every single month in people of reproductive age. Proliferative phase, secretory phase, shedding, repeat. The myometrium, on the other hand, is much more stoic. It's smooth muscle built for one thing: contraction. Histologically, these two tissues could not behave more differently, and that difference is exactly why we must identify them clearly on every slide. From the lab standpoint, endometrium equals glands and stroma. Myometrium equals interlacing smooth muscle bundles. When a pathology report says tumor invades 40% of the myometrium, that statement exists entirely because a histotech cut the tissue cleanly enough to measure it. No pressure, just extremely important. Now we officially enter the land of uterine pathology, where hormones, proliferation, and smooth muscles sometimes behave and sometimes absolutely do not. This slide sets the stage for two major problem zones: endometrial disorders. These are typically related to hormonal imbalance, prolonged estrogen exposure, and abnormal glandular proliferation. This includes things like endometrial hyperplasia and endometrial carcinoma. These processes usually begin in the glands and expand outward, which is why identifying gland to stroma ratios histologically becomes such a big deal. Then there's myometrial disorders. These are mostly smooth muscle based, with leiomyomas being the rock stars of uterine pathology. Fun fact your patients know well, fibroids are extremely common and extremely underappreciated. From our side of the microscope, well circumscribed means likely benign. Infiltrated, irregular, necrotic, now we're asking harder questions. As histotechnologists, this is where our technical skill truly matters. Adequate fixation, clean sectioning, intact endometrial myometrial interface, because that interface often tells the entire diagnostic story. Now we're moving into one of the most commonly discussed and commonly misunderstood uterine disorders, endometriosis. At its most basic level, endometriosis is when endometrial tissue decides it no longer wants to follow the rules and ends up outside the uterine cavity. Normally, the endometrium is very well behaved. It lines the uterus, responds to hormones, sheds monthly, and repeats the cycle. In endometriosis, that same tissue shows up where it absolutely does not belong, and then continues acting like it's still inside the uterus. This condition affects roughly 10% of individuals between ages 20 and 40, which makes it far more common than most people realize. Clinically, this explains why patients may experience chronic pelvic pain, painful menstruation, and infertility. And here's the key concept. These endometrial implants can deposit almost anywhere: ovaries, uterine ligaments, abdominal wall, fallopian tubes, basically wherever gravity, fluid movement, or biology allows. Despite being misplaced, the tissue still responds to hormones, so every month it swells, breaks down, and bleeds, but with nowhere for the blood to go. That trapped bleeding triggers inflammation and fibrosis, which is why endometriosis becomes progressively painful over time. And just to preview what's coming next, when this same process happens inside the uterine wall, it gets its own special name. Here we're looking at what endometriosis actually looks like grossly. On the left image, you can see endometriotic implants on the outer surface of the uterus. These lesions often appear as small, dark nodules, sometimes called powder burn lesions, because of their black, blue, or brown coloration. That color comes from repeated cycles of hemorrhage, breakdown, and iron deposition over time. On the right side, we see one of the more classic findings, an ovarian endometrioma, commonly referred to as a chocolate cyst. And yes, that is exactly as gross as it sounds. The cyst fills with thick, dark, old blood from repeated bleeding cycles. Over time, it develops that brown, syrup-like appearance, hence the chocolate nickname. From a histology standpoint, these lesions contain endometrial glands, endometrial stroma, and hemosiderin-laden macrophages. That triad is your diagnostic jackpot. From histotech adjacent fact, if you ever see hemosiderin macrophages in an ovarian lesion, your brain should immediately whisper, could this be endometriosis? This is one of those diagnoses where the clinical history, gross appearance, and microscopic features all line up beautifully, assuming you know what you're looking at. Now we're taking one step deeper, literally, into the uterine wall. When endometrial tissue grows within the myometrium instead of outside the uterus, we call it adenomyosis. Think of it this way. Endometriosis equals endometrium outside the uterus. Adenomyosis equals endometrium inside the muscle wall. Same tissue, different zip code. On the left images, you see normal myometrium. Firm, uniform, smooth muscle with no interruptions. On the right, the myometrium looks thickened, spongy, and irregular. That's because endometrial glands and stroma are scattered throughout the muscle, causing repeated bleeding and reactive smooth muscle hypertrophy. Grossly, adenomyosis often gives the uterus a boggy texture, diffusely enlarged appearance, poorly defined borders between endometrium and myometrium. Histologically, you'll see endometrial glands at least several millimeters below the endometrial-myometrial junction, surrounding smooth muscle hyperplasia, and evidence of chronic hemorrhage. Clinically, adenomyosis presents with heavy menstrual bleeding, painful menses, and enlarged uterus. And unlike fibroids, which form nice, clean nodules, adenomyosis tends to blend into the wall, making surgical removal difficult without hysterectomy. From a lab standpoint, this is one of those diagnoses where good sectioning and orientation matter. If the interface between endometrium and myometrium isn't well represented, adenomyosis can be easily missed. So yes, even grossing technique plays a role in diagnosis here. On this slide, we're transitioning into malignant disease of the uterus, specifically endometrial carcinoma. This is the most common gynecologic malignancy in the United States, and it originates from the endometrial lining rather than the myometrium. Clinically, this cancer most often affects postmenopausal women with the average age of diagnosis around 60 years old. The hallmark presenting symptom, and the reason many cases are caught relatively early, is abnormal uterine bleeding, especially bleeding after menopause, heavy or irregular bleeding in older patients. And from a treatment standpoint, hysterectomy is the primary therapy, often combined with radiation and chemotherapy, depending on tumor grade, depth of invasion, and stage. From a pathology perspective, this disease is all about glandular malignancy, abnormal proliferation, and invasion into the myometrium, which becomes clinically important for staging. Here we are looking at a gross hysterectomy specimen with endometrial carcinoma. Grossly, these tumors often appear as irregular, friable, exophytic masses, thickened endometrium, papillary or cauliflower-like growths. The surface may look gray-white, tan, necrotic, or hemorrhagic, depending on tumor grade. Unlike benign processes such as polyps or hyperplasia, carcinoma typically shows loss of smooth endometrial contour and infiltrative growth. Areas that appear soft, crumbly, or necrotic as well. For histotechnologists, this specimen highlights why proper sampling is essential. Sections must include tumor, adjacent uninvolved endometrium, the tumor-myometrium interface, because depth of myometrial invasion directly impacts staging and prognosis. This is one of those specimens where orientation and thoughtful grossing make a huge diagnostic difference. This image zooms in on one of the most critical features of endometrial carcinoma, the myometrial invasion. You can see how the tumor extends from the endometrium downward into the myometrium rather than remaining confined to the surface. This depth of invasion is essential because less than 50% of myometrial invasion lowers the stage, better prognosis. Greater than 50% invasion, we have a higher stage and increased risk of spread. Grossly, invasion may appear as irregular thickening, yellow-tan infiltrative areas, and poorly defined tumor borders. Histologically, this corresponds to malignant endometrial glands, crowding and atypia, and destruction of normal smooth muscle architecture. For histology, this is where good fixation, careful embedding, and perpendicular sections matter enormously, because staging decisions depend directly on what we can see on the slide. So in short, depth matters, orientations matter, you matter. This gross specimen demonstrates endometrial carcinoma, again, the most common malignancy of the female reproductive tract in the U.S. Endometrial cancer arises from the endometrial lining of the uterus and typically presents in postmenopausal women, most often around 60 years of age. So grossly, the uterus shows irregular, friable tumor tissue, exophytic growth into the uterine cavity, and a soft, granular or papillary appearance. Areas of necrosis and hemorrhage as well. Rather than forming a smooth, well-circumscribed mass, endometrial carcinoma tends to create a ragged, cauliflower-like surface that replaces the normal endometrium. In this specimen, the tumor thickens and distorts the endometrial cavity, extends along the uterine surface, and it may invade downward into the myometrium. The depth of myometrial invasion is extremely important because it directly affects tumor staging, treatment decisions, and prognosis. On histologic sections, these tumors most commonly show malignant endometrial glands, back-to-back gland formation, loss of normal gland-stroma ratio, and cytologic atypia and mitotic activity. As invasion progresses, malignant glands infiltrate between smooth muscle bundles of the myometrium. A histotech fun fact, endometrial carcinoma is one of the cancers where bleeding is the blessing. Postmenopausal bleeding often leads to early detection, which is why many cases are diagnosed at an early stage with an excellent prognosis. This slide introduces one of the most common uterine tumors you will ever encounter, leiomyomas, more commonly known as fibroids. Leiomyomas are benign tumors of smooth muscle, arising from the endometrium and extremely common in individuals of reproductive age. In fact, by age 50, the majority of people with a uterus will have at least one fibroid, whether they know it or not. These tumors are hormone responsive, particularly sensitive to estrogen. And because of this, fibroids tend to grow during reproductive years, enlarge during pregnancy, and shrink after menopause. They are most often discovered during a routine pelvic exam and on ultrasound, incidentally during imaging for something entirely related. Clinically, leiomyomas may be completely asymptomatic or responsible for symptoms such as abnormal uterine bleeding, pelvic pain, pelvic pressure or heaviness, and reproductive complications. One important feature to remember is that multiple tumors are usually present, not just one. If you see a single fibroid grossly, it's worth assuming there are others nearby. Leiomyomas are polite tumors. They grow by pushing tissue aside, not invading it. That well-circumscribed border you'll see grossly and microscopically is a huge clue that you're dealing with a benign process. A fun but useful fact, despite how dramatic they can look grossly, some weighing several pounds, leiomyomas almost never become malignant. Size does not equal cancer. Big does not mean bad. Ugly does not mean malignant. Pathology rule number 1 still applies. This image shows the classic gross appearance of uterine fibroids, again also known as leiomyomas. Grossly, these tumors are typically well circumscribed, firm, round to nodular, and white to tan in color. If you were to cut into one of these lesions, which pathologists absolutely love to do, you would see the characteristic whorled appearance. That whorled pattern reflects bundles of smooth muscle cells arranged in intersecting fascicles. Basically, smooth muscle doing what smooth muscle does best, lining up in tiny little spirals. These tumors often distort the normal uterine contour, giving the uterus a lobulated, bulky, or bumpy road appearance. You can also appreciate in this specimen that multiple fibroids are present simultaneously. They vary in size, some small, some quite large. They arise within the myometrium, not the endometrium. Important histology to gross correlation. Because leiomyomas grow by expansion rather than invasion, they compress surrounding tissues, create a pseudocapsule, and maintain sharply defined borders. That's why they shell out so cleanly during surgery. Surgeons love them almost as much as pathologists do. Fun pathology fact, fibroids are sometimes described as the onions of the gynecologic pathology. Why? Because they have layers and rings, and they make people cry, just not the histotechs. This specimen shows the uterus open to reveal multiple leiomyomas within the myometrium. Notice several important gross features here. 1. Well-circumscribed nodules. Each fibroid appears round to oval, sharply demarcated from surrounding myometrium, and pale white to tan. This clear border reflects the fact that leiomyomas are benign, expansal tumors, not infiltrative. They push normal tissue aside rather than invading it. Number 2 is the classic whorled cut surface. On cross-section, the fibroids display the hallmark whorled swirling pattern. This pattern corresponds to interlacing bundles of smooth muscle, uniform spindle-shaped cells, and minimal stromal background. Histotechs, this is one of those lesions where the gross image almost perfectly predicts the microscopic appearance. If you see whorls grossly, you're already halfway to the diagnosis. Number 3, variable location within the uterus. This slide nicely demonstrates that fibroids can arise in different anatomic positions. We have intramural, which is within the myometrium, and this is the most common. We have submucosal, which is bulging towards the endometrial cavity. And we have subserosal, which is projecting outward from the uterine surface. Location matters clinically because it influences symptoms. Submucosal results in heavy menstrual bleeding. Intramural is uterine enlargement and cramping, and then subserosal is pressure symptoms, like on the bladder and the bowel. Same tumor, very different patient experience. Number 4, distortion of the uterine cavity. You can see how these masses compress the endometrial cavity, alter the uterine shape, and create irregular contours. This distortion explains why fibroids can be associated with infertility, recurrent pregnancy loss, and difficulty with implantation. All mechanical, not malignant. When this specimen hits your microtome, expect uniform spindle cells, eosinophilic cytoplasm, elongated cigar-shaped nuclei, minimal atypia, and rare mitoses. In other words, boring in the best possible way. A fun pathology fact, leiomyomas are the most common tumor in women. By age 50, up to 70 to 80% of women will have at least one fibroid. Many never know it. Pathology motto applies perfectly here. Common things are common, and fibroids are extremely common. This slide shows large uterine leiomyomas that have undergone degenerative change, which is extremely common as fibroids increase in size. Remember, fibroids grow faster than their blood supply. When that happens, parts of the tumor begin to break down. As leiomyomas enlarge, blood vessels cannot adequately penetrate the center. Ischemia develops. Smooth muscle cells undergo degeneration. Think of it like a city that outgrows its plumbing system. The outskirts are fine, but the middle starts falling apart. Notice that these fibroids are no longer uniformly firm and white. Instead, you can see yellow-tan softening, irregular cystic spaces, areas of hemorrhage, and loss of the classic tight whorled pattern. These changes explain why fibroids can look dramatically different from case to case. Some common types of degeneration are the hyaline degeneration, which is most common, so it represents about 60%. Smooth muscle replaced by acellular eosinophilic material. Grossly appears pale, glassy, or yellow-white. It's seen prominently in this specimen. Then there's cystic degeneration. So that's liquefaction of the hyalinized areas. It produces the fluid-filled cavities, and it's responsible for the softer, spongy appearance here. Then there's red degeneration, which is associated with pregnancy. So acute venous thrombosis within the tumor, it grossly appears red-brown, hemorrhagic, and is painful clinically. It's not pictured here, but students love the name. Calcification, these are more common post-menopause, so can produce popcorn calcifications on imaging. Yes, popcorn. Radiology wins that one. So degenerative change does not mean malignancy. It does not indicate leiomyosarcoma. This is a critical distinction. Leiomyosarcoma is not the malignant transformation of fibroids. It arises de novo. Pathology Pearl, a degenerating fibroid may look ugly, but it's still benign. Microscopically, you may see loss of cellular architecture, eosinophilic hyaline material, cystic spaces, scattered hemorrhage, and minimal mitotic activity. Again, degeneration does not equal cancer. A fun fact, despite how dramatic these can appear grossly, less than 1% of uterine smooth muscle tumors are malignant. Fibroids may be annoying, painful, and inconvenient, but they are overwhelmingly benign. So take-home message, leiomyomas are benign smooth muscle tumors. The estrogen promotes growth, and multiple tumors are common, and degenerative changes are expected in large lesions, as well as gross appearance can vary widely. As for histotex, if it's well circumscribed and whorled, even if messy, think fibroid first. All right. We're officially moving on from the uterus, heading next door to its close anatomical neighbor, the ovary. So think of this slide as our anatomic reset button. Up to this point, we focused on the disorders involving the endometrium, the myometrium, smooth muscle tumors, and hormonal effects on uterine tissue. Now we shift gears to an organ whose entire job revolves around hormone production, follicle development, ovulation, and occasionally causing absolute chaos when something goes wrong. The ovaries may be small, but they are biologically powerful, and when pathology develops here, symptoms can be subtle, vague, or completely silent until things are advanced. From a histotechnology standpoint, ovarian pathology is especially important because gross findings can be dramatic, tumors can be deceptively large, and histologic classification often drives treatment decisions. So as we move forward, pay close attention to gross appearance because ovarian lesions often give us valuable clues before we ever get to the slide. The most common ovarian abnormality you'll encounter by far is ovarian cysts. And the good news, most ovarian cysts are benign and functional, meaning they're related to the normal menstrual cycle. The two most common types are follicular cysts and luteal or corpus luteum cysts. These form when something in the ovulation process doesn't go exactly as planned. Basically, when the ovary says, I tried my best, but biology had other ideas. Grossly and clinically, these cysts are typically smooth-walled, thin, and filled with clear serous fluid. Typically, they are usually small, but they can reach 4 to 5 centimeters, which is about the size where patients and providers start paying attention. Patients may experience pelvic pain, a feeling of pressure, or a palpable mass during exam. Diagnosis is often made by ultrasound, which is excellent at identifying fluid-filled structures, wall thickness, septations, and whether the lesion looks suspicious or not. Most functional cysts resolve on their own, but large or persistent cysts may require surgical intervention. Most ovarian cysts are asymptomatic and are found completely by accident during imaging for something totally unrelated. Here we see a gross example of an ovarian cyst, so notice several key features that help distinguish cysts from solid ovarian tumors. The lesion appears thin-walled, the surface is generally smooth, the cavity is fluid-filled, not solid, there is minimal nodularity. This gross appearance fits perfectly with a functional cyst rather than a neoplastic process. When these specimens arrive in the histology lab, the most important grossing considerations include measuring the cyst size accurately, describing wall thickness, noting the color and clarity of cyst contents, and thoroughly sampling any areas that appear thickened, hemorrhagic, or irregular. Why? Because while most cysts are benign, ovarian pathology always carries a just-in-case clause. Right? Hemorrhage within a cyst, usually luteal cyst, is extremely common and can make the specimen look alarming even when it's not malignant. Histologically, you'll typically see flattened or attenuated epithelial lining, evidence of hemorrhage, and absence of invasive growth. If the cyst wall looks smooth and boring under the microscope, congratulations, pathology loves boring. The ovary is one of the few organs where size alone does not predict malignancy. Small lesions can be dangerous and massive ones can be completely benign, which keeps life interesting and pathologists humble. On this slide, we're looking at a large ovarian cyst, and this is a great example of why these lesions are so commonly discovered on imaging. Grossly, notice how the ovary is markedly enlarged, the surface is smooth, thin, and translucent, the cyst wall appears taut, almost balloon-like. This appearance is classic for a functional ovarian cyst, most commonly a follicular cyst. These develop when a dominant follicle fails to rupture, fluid continues to accumulate, the follicle just keeps growing instead of ovulating. Inside, these cysts are typically filled with clear, straw-colored serous fluid. If you section this, you'd expect to see a thin cyst wall lined by flattened or attenuated granulosa cells and minimal cellular atypia. A fun fact, some follicular cysts can reach the size of a grapefruit, yet still be completely benign. Ovaries are surprisingly patient organs. Now, this image shows the opened internal surface of an ovarian cyst, allowing us to evaluate the gross architecture of the lesion rather than just its external appearance. When we open an ovarian cyst, what we are primarily assessing is the inner lining, the wall thickness, the presence of or absence of solid components, and whether the surface appears smooth or irregular. All of these features help guide the pathologist towards whether the lesion is likely benign or malignant. In this specimen, notice that the cyst is thin-walled, has a smooth, glistening internal surface, lacks papillary projections, it shows no obvious solid nodules. The internal surface appears translucent and pale pink, with delicate surface vasculature visible beneath the lining. These features are characteristic of a benign cystic ovarian lesion. When evaluating ovarian cysts, the inside surface is far more diagnostically important than the outside. Pathologists are specifically looking for papillary excretances, thickened or irregular walls, areas of hemorrhage or necrosis, and solid mural nodules. Their absence, as seen here, strongly favors a non-neoplastic or benign process. A smooth internal lining like this is commonly seen in functional ovarian cysts, so follicular cysts or corpus luteus cysts, serous cystadenomas, occasionally simple inclusion cysts. These lesions are typically unilocular, thin-walled, filled with clear or straw-colored fluid. When this cyst is sampled and examined microscopically, you would expect to see simple cuboidal to low columnar epithelium, often ciliated if serous in origin, a thin fibrous cyst wall, no epithelial stratification, no atypia, no invasion. This epithelial simplicity is key. Once the lining becomes stratified, complex, papillary, or shows nuclear atypia, the diagnosis shifts towards borderline or malignant ovarian neoplasms. Remember, the ovary is a hormonally dynamic organ. Normal cyclic changes in follicular development, ovulation, corpus luteum formation, and create repeated opportunities for fluid accumulation, cyst formation, surface epithelial invagination. That's why ovarian cysts are extremely common, especially in reproductive age patients. This specimen shows a multiloculated ovarian cyst, meaning the cyst is divided internally by septa. Grossly, you'll notice multiple interconnected cystic spaces, thin internal membranes, smooth, glistening lining. This appearance is commonly seen in benign serous cysts and functional cyst variants, and even early benign epithelial tumors. Important distinction here, multiloculated does not automatically mean malignant. What matters more is thickness of septa, presence of solid areas, papillary projections, and surface irregularity. In this specimen, the septa are thin, no solid masses are present, the lining remains smooth, all features that favor a benign cystic process. Microscopically, you'd expect simple cuboidal to flattened epithelium, clear serous fluid, minimal inflammation, and no cytologic atypia. A worthless but fun knowledge, the word serous comes from the Latin serum, meaning watery. Pathologists basically named it. Yep, that's wet. Key takeaways. Ovarian cysts are extremely common. Most are functional and benign. Size alone does not determine malignancy. And gross clues matter. So smooth walls equals reassuring. Thin lining equals functional. Solid nodules is a red flag. On this slide, we're looking at polycystic ovarian disease, commonly shortened to PCOS, and despite the name, this condition is not actually caused by true ovarian cysts. Instead, what we're seeing are numerous enlarged follicles that began developing but never quite made it to ovulation. Think of it like this. The follicles signed up for the marathon, they trained hard, they showed up on race day, and then never crossed the starting line. Histologically and grossly, the ovary often appears enlarged, with a smooth, thickened capsule and multiple cystic follicles lined up along the periphery. This classic appearance is often described as a string of pearls configuration. Those follicles are stalled in development because ovulation never occurs, meaning no dominant follicle is released. Clinically, PCOS is characterized by hyperandrogenism, which is excess androgen production, menstrual irregularities, chronic anovulation, and decreased fertility. From a pathology standpoint, it's important to remember these are functional follicles, not neoplastic, not inflammatory, and not malignant, just hormonally confused. A histology fun fact, because ovulation does not occur regularly, there is no corpus luteum formation, which contributes to progesterone deficiency and ongoing estrogen stimulation, a key link between PCOS and increased risk of endometrial hyperplasia. So yes, ovarian pathology and uterine pathology often hold hands here. Now we move from functional disorders into true ovarian neoplasms, and this is where ovarian pathology gets both fascinating and slightly terrifying. The ovary is uniquely capable of producing many different tumor types because it contains germ cells, stromal cells, and surface epithelial cells. In other words, the ovary is a histologic buffet. Because of that diversity, ovarian tumors are classified based on cell of origin, not appearance alone. And here's the key feature. About 90% of ovarian malignancies arise from the surface epithelium. Not germ cells, not stromal cells, the surface epithelium. This is why epithelial ovarian cancers account for the majority of ovarian cancer deaths. They often grow silently and present late. From a histology standpoint, surface epithelial tumors resemble fallopian tube epithelium, endocervical epithelium, or intestinal type epithelium, which explains why ovarian tumors can look surprisingly unrelated to ovaries. Pathology plot twist there. Some worthless but fun knowledge: the ovarian surface epithelium is technically misnamed. It's actually modified mesothelium, not true epithelium. Pathologists noticed this decades ago and collectively said, too late to rename it now. This slide zooms in on the most important group, surface epithelial ovarian tumors. These tumors are classified into three broad categories: benign, borderline, and malignant. And yes, borderline is a real diagnostic category, not pathologists being indecisive. The benign tumors are well differentiated and no stromal invasion seen. They have an excellent prognosis. Borderline tumors are cellular atypia is present, there's no destructive invasion, and it often occurs in younger patients. These can recur but are usually slow growing. And then there's malignant tumors that have an invasive growth, highly metastatic potential, and often diagnosed late. Most surface epithelial tumors fall into two major patterns: serous tumors, which secrete thin, watery fluid, and they're the most common type overall, and they range from benign to highly malignant, or mucinous tumors, which secrete thick, sticky mucin, can become enormous, and also range from benign to malignant. If you've ever seen a 20 to 30 centimeter ovarian mass in gross lab, that was probably mucinous. Now let's look at the examples listed. A serous cyst adenoma is usually benign. It's a thin-walled cyst that has clear serous fluid and is lined by ciliated epithelium resembling the fallopian tube. This is the well-behaved one. Then there's mucinous cyst adenocarcinoma, which is malignant. It produces thick mucin. It can rupture and seed the peritoneum and is associated with pseudomyxoma peritonei, which is exactly as unpleasant as it sounds. Histology Pearl: when evaluating ovarian tumors, the key feature is stromal invasion. No invasion equals benign or borderline. Invasion is malignant. The cells can look wild, but invasion is the deal breaker. Big picture takeaway for histotechnologists: ovarian tumors are often large, are frequently cystic, and may appear deceptively smooth, and absolutely require thorough sectioning, because that one tiny invasive focus hiding in a sea of cyst wall, well, that's the diagnosis. On this slide, we're looking at a classic example of a serous surface epithelial tumor of the ovary, one of the most common ovarian neoplasms you'll encounter. Grossly, serous tumors tend to be large, cystic, smooth-walled, and filled with clear, watery, or serous fluid. If you hear the word serous, think serum-like, thin, pale, almost straw-colored fluid. These tumors often look deceptively benign on the outside, nice and smooth, shiny capsule, very polite looking. Polite tumors can still be jerks microscopically. Serous tumors can be benign, as in a serous cyst adenoma, or borderline or malignant, as in a serous carcinoma. From a histology standpoint, these tumors are lined by simple cuboidal to columnar epithelium, often resembling fallopian tube epithelium, sometimes even with ciliated cells. High-grade serous carcinoma, the deadliest ovarian cancer, is now believed to originate in the fimbriae of the fallopian tube, not the ovary itself. The ovary just ends up being blamed. Classic case of misplaced guilt. Now we shift gears from watery to, well, sticky. These images show mucinous ovarian tumors, which secrete thick, gelatinous mucus instead of clear fluid. Gross characteristics include very large size, often among the largest tumors in the human body. They are multiloculated cysts, so lots of internal compartments. They are filled with thick, viscous mucin, and some of these tumors can weigh 10 to 20 kilograms. Yes, kilograms. That's not a typo or a misspeak. From a histology standpoint, mucinous tumors are lined by tall columnar epithelial cells, abundant intracytoplasmic mucin, and cells resembling intestinal or endocervical epithelium. Classification again follows the same rules. A mucinous cystadenoma is benign, a borderline mucinous tumor, and then the mucinous cystadenocarcinoma is malignant. Unlike serous tumors, mucinous tumors are less commonly bilateral, often extremely large before detection, and most likely to rupture if not removed carefully. And if mucin spills into the peritoneal cavity, you get a pseudomyxoma peritonei, a condition where mucin literally coats abdominal organs. So pathology translation, the abdomen turns into biological bubble wrap. Not ideal. This final slide highlights one of the most important malignant features you should recognize, papillary architecture. What you're seeing here are complex branching papillae, irregular surfaces, nodular excretances protruding into cystic spaces. In ovarian pathology, papillary projections should always raise concern for malignancy. Histologically, malignant serous tumors often show stratified epithelium, nuclear pleomorphism, prominent nucleoli, increased mitotic figures, and psammoma bodies, those laminated calcifications we all secretly love. If you see papillae, solid areas, necrosis, and surface excretances, you are no longer in benign territory. A clinical pearl for histotechnologists, these tumors often require extensive sampling, multiple sections per centimeter, careful evaluation of capsule integrity, because ovarian cancers love to spread by surface exfoliation, peritoneal seeding, and ascites, which explains why many patients present late. Ovarian tumors can grow silently until they're massive, hence the nickname, the silent killer. So quick takeaways, serous tumors are going to be watery fluid, fallopian tube-like epithelium. Mucinous tumors are thick mucus, intestinal type epithelium. Papillary structures plus surface nodules equals red flag. And gross appearance often hints at diagnosis, but histology confirms it. Ovarian tumors equal epithelial until proven otherwise. Now we're shifting gears from surface epithelial tumors to germ cell tumors of the ovary. Remember, germ cells are the cells meant to become ova, so when they go rogue, things can get interesting. And by interesting, I mean weird in the most pathology appropriate way possible. Grossly, these tumors appear large, unilateral, well circumscribed, and very different from the smooth, thin-walled cysts we saw earlier. Unlike epithelial tumors that grow from the surface inward, germ cell tumors arise from within the ovary itself, which is why they often expand and distort the ovarian architecture. This image shows a bulky ovarian mass with solid and cystic areas, irregular internal surfaces, and regions of hemorrhage and necrosis. That mixed appearance should immediately raise the thought of germ cell origin, especially when you see variability rather than uniform fluid-filled spaces. Histologically, these tumors reflect their embryologic roots, meaning they may contain tissue types that have absolutely no business being in an ovary. So let's break these down. Teratomas. They are by far the most common germ cell tumor. They occur most often between ages 20 and 45, and thankfully almost all are benign. Teratomas arise from the totipotent germ cells, meaning they can differentiate into tissue from ectoderm, mesoderm, and endoderm, which explains why they may contain skin, hair, sebaceous material, teeth, bone, or cartilage. Pathologists love teratomas because they're basically a final exam in embryology inside a cyst. Then there's dysgerminoma, ovarian counterpart to the testicular seminoma. It's a typically solid tumor. It's composed of large primitive germ cells and often occurs in younger patients. Histologically, they show sheets of uniform cells with clear cytoplasm and central nuclei, so very similar to what you'd see in a seminoma slide. And then there's choriocarcinoma. It's rare and aggressive. It produces HCG, and it's highly malignant. It tends to hemorrhage extensively. Thankfully uncommon, but very important clinically due to its aggressive nature in hormone production. And here we have the fan favorite, the teratoma, also affectionately known as the "why is there a tooth in my specimen" tumor. Grossly mature cystic teratomas, often called dermoid cysts, have very characteristic features: thick cyst wall, yellow greasy sebaceous material, matted hair floating in lipid-rich fluid, and sometimes a fully formed tooth. And if you've ever wondered why histotechs gag during gross lab, this is usually the reason. That thick yellow material is keratin and sebum produced by skin adnexal structures inside the tumor. Histologically, you may see stratified squamous epithelium with hair follicles, sebaceous glands, respiratory epithelium, neural tissue, bone, or cartilage, all in one specimen. A fun but horrifying fact, these tumors arise from a single germ cell that basically says, you know what, I'm going to try to become an entire organism today. Fortunately, mature teratomas are benign, and surgical removal is typically curative. Immature teratomas, which contain embryonic tissue, are a different story and carry malignant potential, but those are far less common. On this slide, we're looking at another teratoma, specifically a mature cystic teratoma, which is also, again, commonly referred to as a dermoid cyst. Again, teratomas are germ cell tumors, meaning they arise from the totipotent germ cells. The cells are capable of differentiating into tissues from all three embryonic germ layers, the ectoderm, mesoderm, and endoderm. Because of this, teratomas can contain a wide variety of tissue types. Grossly, again, they often contain skin, hair, sebaceous material, fat, and occasionally even teeth or bone. In this image, the presence of hair and greasy yellow sebaceous material is a classic gross feature and is essentially diagnostic of a mature cystic teratoma. These tumors are very common ovarian neoplasms, most frequently diagnosed in individuals between 20 and 45 years of age. Almost always benign. Although benign, they can still cause clinical symptoms due to ovarian enlargement, abdominal or pelvic pain, and ovarian torsion, which is one of the most common complications. From a histology standpoint, sections may reveal stratified squamous epithelium with skin appendages, adipose tissue, respiratory or gastrointestinal epithelium, and even occasionally neural tissue. Because multiple tissue types can be present, sampling is extremely important to ensure no immature or malignant elements are identified. So when you see a cystic ovarian mass containing hair, sebaceous debris, or tooth-like structures, think mature cystic teratoma, benign, germ cell origin, and unmistakably gross. This slide introduces ovarian stromal tumors, which arise from the sex cord stromal component of the ovary, essentially the connective tissue and hormone-producing cells that support follicular development. Unlike epithelial tumors, which dominate ovarian malignancies, stromal tumors are far less common and are most often benign. The two major types highlighted here are fibromas and thecomas. Fibromas are the most common ovarian stromal tumor. They are benign, composed of spindle-shaped fibroblasts, rich in collagen. Grossly, fibromas appear solid, firm or rubbery, and white to tan, often described as looking very similar to a uterine leiomyoma. Histologically, you'll see interlacing bands of bland spindle cells, abundant collagen, and very low mitotic activity. A classic association to remember is Megg's syndrome, which includes ovarian fibroma, ascites, and pleural effusion. And yes, once the tumor is removed, the fluid typically resolves. Pathology magic. Then thecomas arise from theca cells, which are hormonally active cells involved in estrogen production. Because of that, thecomas can secrete estrogen, occasionally secrete androgens. Grossly, thecomas appear yellow to orange due to intracellular lipid content. They are softer than fibromas, and that yellow coloration is a big clue for histotechnologists. Lipid equals hormone production. Clinically, excess estrogen can lead to endometrial hyperplasia, abnormal uterine bleeding, and increased risk of endometrial carcinoma. Histologically, thecomas show plump spindle to polygonal cells, lipid-filled cytoplasm, and fewer collagen bundles compared to fibromas. Key takeaway, if the ovarian mass is white, firm, collagen-rich, think fibroma. If it's yellow, lipid-rich, hormone-producing, think thecoma. Both are stromal in origin, typically benign, and excellent examples of how gross appearance often mirrors microscopic behavior. All right, that brings us to the end of our section on disorders of the female genitalia with a major focus on ovarian pathology. At this point, you should be comfortable recognizing the big picture categories of ovarian disease, even if you're not memorizing every tumor subtype. Because in real laboratory practice, pattern recognition matters far more than trivia, right? Over the last several slides, we've covered functional disorders such as polycystic ovary disease, surface epithelial tumors, which account for the vast majority of ovarian malignancies, germ cell tumors, including teratomas. Yep, that's the tumors that bring their own hair and teeth. Stromal tumors like fibromas and thecomas, where hormone production becomes clinically important. From a histotechnology perspective, the key themes to take away are cell of origin matters, so epithelial, germ cell, or stromal. Gross appearance often provides important clues. Hormonal activity can explain clinical symptoms, and ovarian tumors frequently present late because the ovary has plenty of room to grow quietly. If you're looking at a specimen and thinking, why is this ovary massive? Why is it solid instead of cystic? Why is it yellow? Why does it look like it came from a horror movie prop department? You're asking exactly the right questions. This is a good moment to pause and remind you are not expected to diagnose ovarian tumors as histotechnologists, but you are expected to understand what tissue you're processing, why special stains or IHC may be ordered, and why gross description and section selection matter, and how microscopic features connect back to disease processes. Again, if you have questions, need clarification, or want to revisit any of these topics, just please reach out to me via email or come to office hours. As always, thank you for sticking with me through some very dense material. Ovarian pathology is not light reading, but you handled it beautifully. So take a breath, grab some water, and yeah, we'll move forward from here.